let's get started. Today we will be discussing tailoring CMV prophylaxis based on a CMV T-cell immunity panel assay in kidney transplant patients. I'm your host, Denai Wells, Product Marketing Manager for Eurofins FibroCore. If you have any questions during today's presentation, please click on the question mark icon in the navigation menu to submit, and we will address as many questions as we can with the time remaining after the presentation is concluded. Now, I would like to introduce Dr. Clifford Miles. Dr. Miles is an Associate Professor of Medicine in the Division of Nephrology at the University of Nebraska Medical Center. Dr. Miles is a board-certified nephrologist and the Medical Director of UNMC's Kidney and Pancreas Transplant Program. He is originally from Omaha, completing his medical school at the University of Nebraska, and he completed residency at Dartmouth and fellowship at University of Michigan in Ann Arbor. Dr. Miles is interested in the disease process and the delivery of care to the unique patient population of kidney failure patients, and he sees his primary responsibility as educating and managing patients through the true risks and benefits of kidney transplantation. Welcome, Dr. Miles. Great to have you today.
Thanks, Denai.
All right, let me give you presentation mode, and you can go ahead and share your screens and get started.
Sounds good. If you could just confirm that my slide popped up for everyone, please. Yeah, so yeah, thanks, Denai. My name is Cliff Miles. I'm a transplant nephrologist in Omaha, Nebraska, and it's my pleasure to accept the invitation to lead this webinar today about tailoring CMV prophylaxis using what I think is relatively exciting technology for our patients. Just by way of disclosure, I do have some research funding from Tailoring Therapeutics that's not really relevant to today. And some of what we're going to get to today is the result of a collaboration between our group here in Nebraska and Eurofins FibroCore, utilizing some of their CMV T-cell immunity testing. Just as a brief outline, I'll talk just for a couple minutes because I can't help myself about the background on the lens that we look at this problem through kidney transplant, on the significance of CMV in strategies sort of past, present, potentially future to prevent CMV disease in our patient population. The kidney transplantation, for all, I think, practical purposes, has existed since the mid-1950s and has grown substantially since that time to the point where really for the last several decades, it has been recognized as a treatment of choice for kidney failure. Transplantation offers better patient survival and better quality of life compared to dialysis, and also is more cost-effective, which I think is important in our current environment. We're really limited primarily by the supply of donated organs in terms of transplant. At any given time, approximately a little over 90,000 patients on the kidney transplant waiting list in the United States. And now I think I looked up 2021 was a little over 24,000 kidneys, but still a pretty small fraction. And need to remind everyone, the wait-listed population is still a pretty small fraction of the population in need, which really numbers in the several million if you include people with advanced kidney failure and the rest of the dialysis population. Transplant is good, but as this slide depicts, we're still not really there in terms of what we need to be able to offer to our patients, with overall survival for kidney transplant patients seeming to plateau between 75 and 80% at 5 years. Again, better than dialysis, but really a therapy that we would like to improve upon. Infections are a major cause of mortality and morbidity following kidney transplant. To prevent rejection and maintain graft function, still in 2022, we need long-term immune suppression, and that immune suppression comes with cost. The leading causes of death, including cardiovascular disease, malignancy, and infections, are all impacted by the use of long-term immune suppression. That's been well recognized. When I think of infections, I typically subdivide them into quote unquote typical infections like pneumonia, cellulitis, and particularly in kidney transplant, urinary tract infections. And then opportunistic infections, which loosely speaking are infections that we don't think would occur in patients with normal immune systems, patients who are not immune suppressed. And those are largely made up of fungal and certain viral infections that can be seen in this population. Of the opportunistic infections, I think cytomegalovirus kind of reigns king. It's the most prominent opportunist that we deal with in solid organ transplant. It's a common virus in the U.S. population, with greater than half of adults being seropositive, meaning that if you test them, they have an immunoglobulin G, an IgG against CMV. Probably most of us get it as a childhood infection, shared at daycare, in grade school. And then, as some viruses can do, it goes into a latent phase where it's still present in the body, but it's not replicating and it's not causing any problems. Until, of course, we immune suppress somebody, and even immune compromised patients are at risk of CMV infection, and that comes in several different varieties. So first of all, if patients are seropositive and have latent virus, they can develop reactivation of CMV, whereas if they have not previously been exposed to CMV, they can get a primary infection, which generally can be a little bit more symptomatic, a little more dangerous. Infections can be asymptomatic, and we may run across people who have some viral replication, have a viral load, but they feel fine and are normal. Or they can have actual disease, and that's subdivided into what we sort of refer to as CMV syndrome, malaise, fevers, kind of non-specific symptoms versus specific organ involvement, pneumonitis, enteritis, and even nephritis we can stumble on. And the effects of CMV can either be direct, like the organ it's involving, the lung or the kidney or the gut, or indirect in the form of other infections coming in the setting of CMV, and allograft rejection, which is an important indirect effect of CMV. So I think it makes sense that we've spent a lot of energy over years in the field of transplant worrying about trying to prevent CMV. There are generally two strategies. The use of an antiviral to just give prophylaxis after transplant, or what's known as the preemptive strategy. So prophylaxis in this day and age, oral valganciclovir is the drug of choice and is approved for the prevention of CMV post solid organ transplant. Some of the drawbacks, it may be that we're just kicking the proverbial can down the road and you can see post prophylaxis CMV disease. To counteract this, there's been interest in prolonging prophylaxis in higher risk groups, such as those whose recipient was the recipient was seronegative and the donor was seropositive. That's the nomenclature here, D positive or minus. Preemptive therapy is turned to less in this country. There is a little bit less supporting evidence, but I think the issue is really with logistics and using us as an example. Things like sample acquisition and transport are a big deal when patients may live 4 or 5 hours by car from the transplant hospital. We can get routine things like serum creatinine and hemoglobins run at local hospital labs. But things like PCR are much more difficult, and if you're relying usually on weekly quantitative PCR to successfully do preemptive monitoring, it can really break down and leave people in the lurch. I'd point out that this has been reviewed a couple times, and there are some professional guidelines. This reference at the bottom of the slide is from the American Society of Transplants Infectious Disease Community Practice, and is a great reference. So kind of honing in on what we do. So our CMV protocol, and this is sort of past tense, as we'll get to, we start by risk stratifying, which I think is pretty common. We do look at both the serology, donor and recipient, and the induction agent used for immune suppression at the time of transplant. For patients we consider at higher risk, those are the naive recipients receiving a seropositive donor organ, or if they receive lytic induction, we typically use anti-thymocyte globulin, though we have a little bit of experience with alemtuzumab as well, both of which are categorized as lytic agents for transplant. For these high-risk patients, they get 6 months of prophylaxis against CMV with valganciclovir. And after they come off prophylaxis, we do post-prophylaxis monitoring with PCR at 2, 4, and 8 weeks post-prophylaxis, again, like looking for post-prophylaxis disease. Sort of for the rest, for lower risk patients, which are those who were seropositive recipients, and they received a non-lytic induction, typically basiliximab in our program, they get 3 months of prophylaxis, and we do allow for valacyclovir or valganciclovir at our center. Not mentioned here is that we do have some recipients who are negative and their donor is negative, and they're really not felt to be at risk for CMV and not relevant. So nothing's perfect, right? And so things that we have run into with our CMV prevention strategy, one thing off the top is pill burden. So transplant patients really face an inordinate pill burden. Their immune suppression and blood pressure and cholesterol, and a lot of them are diabetic, or maybe we make them diabetic. So to add sort of one more thing, I think is a real issue. And with valganciclovir, it's expensive, and we try to pay a lot of attention to both what the payer has to pay, but also the out-of-pocket for the patient. And side effects are not uncommon, and really leukopenia and neutropenia are the most common side effect we run into with valganciclovir. Post-prophylaxis CMV, as I mentioned before, is a problem in our post-prophylaxis monitoring. We do come up with people who are viremic, and some of whom get sick and need to be then treated. And you're back to the logistics of sample transport and processing that I was talking about, where maybe a patient lives 3 or 4 hours away, and now they're 6 months out from transplant, and their lab frequency is lower, and they're trying to get that back on with their life. And so it can be an issue if you miss one of these PCRs and then basically get behind with taking care of their CMV. And we do run into, again, cyclovir-resistant CMV strains, and this may be a bigger problem in the future for our field. So, in thinking about this as a team, like what are some of the specific questions and to try to improve upon our practice? I think there's clearly this question of, can some of these people have their prophylaxis stop sooner? Getting to the pill burden and the cost and the avoidance of side effects like leukopenia. And whether you stop it sooner than we do or go for the full period, how can we predict who's at risk of developing CMV despite the prophylaxis that we've used for them? And I think that's sort of led us to get more and more interested in this testing that's coming available, looking at T-cell immunity specific to CMV. There are several commercial assays around, and we've had the most experience with that's developed by Eurofins Vericor. It's a flow cytometry-based assay that does look at both the CD4 and the CD8 populations, looking to see if upon stimulation with CMV-specific antigen, if you see T-cell response for both of the populations, CD4 and CD8. And there's some published literature about it. It's been shown to predict CMV disease, and this work by Rogers that I threw up here showed that for the CD4 positive in particular, if they looked at a cutoff value of 0.22%, and it had a pretty decent predictive value for the absence of CMV. In this study, they drew one CMV T-cell panel at the time patients were coming off prophylaxis, and then sort of watched to see what would happen, who developed CMV and who did not. And again, so it showed that people who had T-cell immunity by this panel were much less likely to develop disease. And so building on that, for our protocol, we amended it by incorporating the CMV T-cell immunity monitoring. We chose to focus on this high-risk group as we define it, so either positive to negative or lytic induction at the time of kidney transplant. Rather than one time point, we are opting to do serial assays starting at 3 months, 3, 4, 5, and 6 months post-transplant. If at any of those time points, well, at 3, 4, and 5, if they have a CD4 positive response by the manufacturer's recommendation of greater than 0.2%, we would stop their prophylaxis and shift into post-prophylaxis monitoring. If patients get to 6 months, at this point, we're still stopping them even if they haven't developed immunity and then going into post-prophylaxis monitoring. So kind of like the old way, I guess. To kind of like how does this really work? So this patient was one of the first people that we took care of after we had amended our protocol. This person EW. So she's a 67-year-old woman with diabetic kidney disease that we transplanted in the May of 2021. Her induction was with anti-thymocyte globulin, which is how she ended up being considered higher risk for CMV in our program. Note that she was donor positive and recipient positive for CMV at the time of transplant. By our protocol, the intent was to give her 6 months of valganciclovir prophylaxis. We give most people 450 milligrams per day, but her GFR was also a little bit below 50, so it sort of fits her. She really had a fairly unremarkable course. She had no episodes of injection, she had no readmissions, and overall did really well. And so we embarked upon monitoring her with these serial CMV T-cell panels. For whatever reason, the first one was a little bit early, but 10 weeks post-transplant. So she has some reactivity, but below the cutoff of 0.2 for the CD4. And so we reviewed this and opted to continue her prophylaxis with valganciclovir and then repeat her assay in 4 weeks. At that point, her CD4 in particular had now climbed above the threshold of 0.2. We reviewed this, we stopped her prophylaxis, and then per protocol switch into her post-prophylaxis PCR monitoring. 2 and 4 weeks post-prophylaxis, there was no detectable CMV DNA, but lo and behold, at 8 weeks, she has this low copy count, 510 IUs per ml, and in one of these values, it's kind of hard to know what to do with. So we call her, like, how are you doing? We look at the rest of her labs, which we are, of course, following, and she doesn't have anything unusual on her labs, and she feels fine. She has no symptoms, kind of, why are you calling me type of conversation. And so we do nothing, and we repeat her CMV PCR, and while technically not negative, it's below the threshold of detection, and she continues to feel well, and we go on about our business. So to date, we've had 61 patients that we have had in this higher risk group that we've looked at with our sort of new way of thinking about CMV prevention, incorporating the T-cell assay post-transplant. Of those, so far 23, or just over a third, had their prophylaxis stopped early because they were immune by this definition that we laid out of having a CD4 positive T-cell panel of greater than 0.2. For all these patients, whether they're stopped early or not, remember they're getting post-prophylaxis PCR screening. For the 28 who were not stopped early, so they did not meet our criteria, 14 of them had viremia, and actually 12 of them ended up needing treatment for CMV. And so that's a clinical definition that the rounding nephrologists make with the nurses, and it's based on, do they have symptoms? Do they have new leukopenia? Do they have a climbing viral load, or some combination of those? There's no reflexive, if the viral load is greater than X, we'll automatically treat. But clearly, you get into the thousands of IUs per ml, our worry is going to go up. For the 23 who stopped early, also 14 of them were noted to be viremic, but like Ms. EW, none of them ended up needing treatment by our sort of clinical rationale. They didn't get sick. They had viral loads that sort of peaked and went away with no intervention. Other observations from this group of patients, 80% of those who were deemed immune were seropositive prior to transplant, so had been exposed to CMV earlier in life. Only 4 of the 30 who were naive and received the donor positive organ developed immunity by T-cell testing. In this group, 36 of them had received lytic induction with anti-thymocyte globulin. 21 of those did achieve T-cell immunity post-transplant. And for all the 23 people who achieved immunity, the median time to detection of that was 4.4 months. We did look at some sort of, I'm going to call them generic variables, and we didn't see the impact of things like age and gender and a few other things we looked at. So where do we go from here? I'll just be honest, we have struggled with our 4 and 5 month time point. For our clinical practice, we see people in clinic on campus at 3 months, and we see them in clinic on campus at 6 months, but at 4 and 5 months, we're typically not having them here, and so they're getting labs often drawn elsewhere. That's been a hurdle. We may be looking at using more mobile phlebotomy or some strategy like that to try to improve our density, especially since we're seeing like immunity may be happening more like 4 or 5 months and less at 3 months. We need to give some consideration to what to do with people who, when we get to 6 months, still don't have T-cell immunity. I think that's kind of an open question, but it is something to think about, whether they're over immune suppressed or not. That's not the purpose of this assay, but it makes you wonder. I think at this point, I'm comfortable saying we're going to continue to stop prophylaxis in people who have a positive T-cell immunity panel. For now, we're going to continue to do post-prophylaxis PCR, but I think we're seeing that this is a reasonable thing to do. And then in terms of like what else can we do with the assay, I think there's probably some utility in trying to risk stratify people who have CMV DNA EMEA positive PCR in other settings. And as like a random example, not too long ago we had somebody admitted with COVID, years out from transplant, but admitted with COVID, who probably not even sure why, but somebody checked their CMV and it's positive at like 500 copies. And you're like, well, what do you do with that? I think potentially risk stratifying them with T-cell immunity may be of some use, though we have not looked at that in any scientific manner. I'm going to end by just trying to acknowledge the outstanding people that I get to work with, Abby and Scott from UNMC, Department of Pharmacy and Nutrition. And then we've had a great partnership with Dr. Kleibacher and Kara and Isabel from Eurofins ViraCore. I'm looking forward to doing more stuff with them in the future. I'm going to stop, and if Denai's technology will allow us, we can try to do some question and answer. And I appreciate everyone's attention today.
Thanks, Dr. Miles. Let me share my screen again. Appreciate your time presenting that really interesting data from the study that you guys did and the great case study. As a reminder to the audience, if you do have any questions, please click on the question mark icon in your navigation menu to submit. We will address as many of them as we can within the remaining time during the Q&A portion. But if you have any other questions or would like to follow up with us, you can reach out to events@eurofins-viracore.com and we can follow up with you directly. But now I would like to welcome Dr. Steve Kleibacher, Chief Scientific Officer of Eurofins US, for the Q&A portion with Dr. Miles. Welcome, Steve.
Thank you, Denai. Thanks also, Dr. Miles, for the really interesting and informative presentation. So I have a few questions for you, if you don't mind, and we wait for hopefully the audience to push through some questions. But I'm really interested in the relatively small but maybe impactful proportion of D+R- patients that developed immunity during the study. Do you find value in testing these seronegative patients during the periods of prophylaxis? And And also just interested in your thoughts on how these patients are developing immunity while on prophylaxis.
Yeah, thanks, Steve. I think that's really interesting. I'm going to be honest, I didn't know what to expect. And going into this, I think I was second guessing whether it was even useful. As we can see, some of these patients, relatively few, but some of them did show up as having immunity. So a couple of thoughts. It could be that, the human body, over time, has, whether you want to call it senescence or whatever, but we may lose detectable IgG, even though we've had prior exposure to a virus like CMV. And that could be one way, how someone who was labeled as recipient negative then turns out to have a positive T cell immunity later. We don't go back and retest their IgG, which may be of interest. The other possibility, and I think that there's potentially more worry about this, is do patients in that setting have some sort of transient viremia? And we're not screening PCRs while they're on prophylaxis generally. So do they have some transient viremia? And that gives them exposure to the antigen, and they're somehow able to mount immunity, albeit in the face of immune suppression. So there's some real unknowns there, but I think it's fascinating how we got that. Really, people we thought didn't have CMV suddenly are immune to it. So.
Yeah, certainly it is. It's interesting what you can find when you look sometimes. So you mentioned immunosuppression, and I know that it's common practice when you have a viral load, you'll reduce immunosuppression to try and give the patient a chance to respond. But have you used this test as an aid in those type of situations? And then just overall, do you have hesitations about reducing immunity when you have patients with the lower CMV PCR results?
Yeah, I'll answer the second part first. I think we have quite a bit of hesitation with reduction of immune suppression in the setting of CMV. As mentioned, one of the indirect effects of CMV infection can be allograft rejection, and maybe someone else does, but I don't understand exactly why that is, because it's a disease that suggests you're over immune suppressed, and yet you can also then reject, which is sort of a disease of under immune suppression at the same time. We have not yet used the CMV T cell for the purpose of trying to adjudicate immune suppression, but I think that's a direction I would really like to look at. And sort of one setting is at the end of the prophylaxis, if they haven't achieved immunity, but also in these people who have some viremia or what have you, if you demonstrate a low T cell response, I think it may make sense to back off on immune suppression, potentially before they get sick, allow them to get treated or recover, and then maybe retest their panel, but then put their immune suppression back up before they then suffer the rejection. Clearly, there's a lot of open-ended questions, and I think this may be a tool that will be of some use trying to navigate.
Yeah, excellent. So perhaps knowing how long to reduce their immunosuppression based upon a T cell immunity panel would be an approach. So another question, in the R positive patients, or well, in the study, I should say, you took your first time point at 3 months. If a patient was suffering from some direct effect of ganciclovir, such as leukopenia, do you think an earlier time point post-transplant could be valuable in R positive patients, or do you think they really need that 3 months to develop any observable immunity?
Yeah, so don't know. I mean, I think it may depend in some way on their induction. I think there's a lot of reasons who had thymoglobulin likely to have suppressed immunity. That's sort of the purpose, is they have more suppressed immunity for a period of months. So just as we go, we do have people who are having enough trouble with, let's say, neutropenia, that we stop their prophylaxis early anyway, regardless of all of this. And I think that may be another setting where I guess I'm saying, we have to stop your valsite anyway. So let's see where we're at, so we know how much we need to worry about CMV. And I would argue that if it was 1 month or 2 months or 3 months, maybe doesn't matter. We can use all the tools that we have at our disposal to try to get through that Because if I have someone who is D plus R minus, who I have to stop their valside, 6 weeks post-transplant, I'm worried. And anything I can use to try to help get through that, I think I'm going to use.
Okay, yeah, very interesting. So really a risk stratification when you have to make those difficult treatment decisions. And then in the study, you used a CD4 positive result as the qualifier for early termination of prophylaxis, and certainly that fits with the findings of Rogers et al. and other flow cytometry-based assays that we see in the literature. How do you interpret a CD8 positive, only a CD8 positive, in other words, CD4 CMV specific result negative, and then the CD8 CMV specific result positive?
Yeah, it's a good question. We've of course collected data. The result of the panel shows both, so the data is easy to collect. And one of the projects that Abby and the team are going to continue to look at is what are the correlations between the CD4 and CD8, but also in people who, let's say, they only have a CD8 responsivity, showing how do they look in terms of the risk of clinical disease, viremia, et cetera. So one question it would be to, I guess, replicate what Rogers and other studies showed, is that the CD4 is more predictive or not, because we'll have a data set that we can look at that in. But then also, do the CD4 and CD8, are they correlated in time? Like, do we see CD8 first? Do we see CD4 first? Does one predict the other temporally? And so I think we have a lot of directions to go to try to analyze this, but we're amassing the data, so I think it's going to be really interesting.
Yeah, definitely no shortage of research topics still to explore here. Yeah, so another question is, and you alluded to this briefly before, is the potential value in pre-transplant testing. We know from the literature some patients have a discordant serology versus the T-cell immunity result, but including that and then just any other factors, do you think there's a future research question around pre-transplant testing that's worth digging into?
Yeah, I think we'll find more questions and answers at this point, but yes, I think that dialysis itself and advanced chronic kidney disease itself is thought to be immune suppressing, and we don't really have good measures of how immune suppressing that is. And so one question is, someone who is on standard triple therapy post-transplant, are they more or less immune suppressed than they were when they were on dialysis? I don't think we really know that. I think we think that they're more immune suppressed when we're giving it to them, but I don't really know that. So patients who have, let's say, a low, a CD4 of 0.1 or something like that, before we even start their immune suppression, you might think of them in a different lens than somebody who has nice, robust T-cell responsiveness to CMV going into it. How exactly to operationalize that, I'm not sure. I mean, but it may be a group that you do more intensive monitoring or change your prophylaxis, that kind of.
Yeah, that does bring up an interesting question in my mind also, and that's about the potential quantitative use of this testing, the CMV T-cell panel. So we certainly have a qualitative interpretation, I think, well established for certain questions, but I've also wondered as I review our results and I see a CD4 value of 1%, 2% or greater, I intuitively think, well, that patient has the lowest risk, but we haven't really amassed enough data yet to defend that sort of a statement. So do you have interest in looking at this potentially as the risk stratification tying into a quantitative value for these markers?
Yeah, I think it'll take more data and more patient outcomes to make much sense of it, but it would stand to reason that would be true if you look at people who have 0.1 versus 0.2 or whatever multiple you want to choose. Both are they at different risk of CMV, but are they people that we need to think their immune suppression different? So I guess if I'm envisioning someone whose CMV specific T cell panel was like 0.4, 0.5, are they at higher risk of rejection? Like, do they have a more robust immune system?
Yeah.
And so I think that's something that with time and diligence, we would be able to start to look at questions like that. We haven't, I don't know off the top of my head, but I don't know that we've had more than just a couple rejections in our current data set. So far from having enough data to think about it that way, but.
Yeah, these will take large data sets to really sort out with confidence the possible clinical meaning of different levels of immunity. So yeah, those are my CMV specific type questions, but just interested from a more personal note, what inspired you to choose neurology as a career path?
Nephrology, God, nephrology. You know, I don't have a great glamorous answer for that. I actually thought I was going to be an oncologist, and I was lured away from oncology by nephrology, partially because I feel like there is, and I'm not meaning any offense to my colleagues in oncology, but there's a little bit of sense of you make a diagnosis and you turn to this vast literature base and you apply the recipes that have been made by people who have gone before you. There's less of that in nephrology, and there's certainly less of that in transplant nephrology. There's very few large randomized controlled trials in transplant nephrology. I feel like we have to sit down and think our way through a lot of these problems. And look at it, we've struggled with CMV for 50 years, and we're still trying to figure out how to even risk stratify people. There are so many unanswered questions, even with something that we know is a huge problem. Then you turn to like BK virus, which is a relatively new problem, in the way the world works. All the unanswered questions there. I think it's a really neat field, and gives us a lot of opportunity for hopefully improvement, but a lot of opportunity no matter what.
Interesting. Well, I'm certainly sure there are lots of patients out there who appreciate the career decision that you made.
Thanks.
Absolutely. It looks like we have a few questions that came in through the chat. So we'll go ahead and tackle those. When was the time of decrease in immunosuppression, and was any connection between post-transplant complications / rejection / BKV infection and CMV reactivation?
I'll see if I can unpack that. So by the protocol, there is no reduction in immune suppression. So that's another thing that we make as sort of clinical practice, looking at sort of a whole picture of how sick is the person, what's their CMV viral load doing, more and more, what do we know about their T cell immunity panel? But then also things like, is it their first transplant? How old are they? Like, what's their general health like? And so there's ample room for being more scientific about adjustments to immune suppression. But in today's practice, it's still, we're flying with, visual reference right now, just going off what we see in front of us. And so I don't know, hopefully that gets at the question. We have a BK virus monitoring protocol for our program. I think all programs do it in this day and age. It's not super scientific. We use serial quantitative PCR. If people have low level BK, we may not do anything. If their BK viral load is climbing, we may empirically reduce their immune suppression. We may biopsy looking for evidence of nephritis, again, kind of through the lens of who is this person? Is it their second transplant and they have 99% PRA? We're probably going to biopsy them before we get crazy about changing immune suppression. So it's a hard question because it brings in a lot of what we do every day, and we're down there, sweating it out in clinic, trying to dance, through these problems.
Yeah, absolutely, thank you. The next question we have is, how do you use this assay in high-risk patients that are CMV positive to CMV negative, donor to recipient, lymphocyte depleting agents at 6 months post-transplant with low CD4 on the assay, and it's time to stop prophylaxis at 6 months.
Yeah, so that kind of gets at the, I think, the highest risk person who is donor positive, recipient negative, and we chose to give them a lymphocyte depleting agent. Maybe they had a high PRA, or hopefully we had a good reason to do that. And you get to 6 months, and maybe not surprisingly, but you get to 6 months and they still don't have a CD4, or maybe make it worse, maybe they also don't have a CD8 responsiveness on their T cell panel. What do? And the more I get into this, the more I think the answer is to empirically reduce their immune suppression. That you're still left with a couple questions. So do you keep the prophylaxis going while you make a change before you stop it? Do you switch to a more traditional preemptive and do more intensive CMVD? Because we only have 3 time points, and we've had some misses, let's just say, where people at their 2 and their 4 they were negative, and then somewhere between 4 and 8 they go from no DNA to 1 million copies and they're in the hospital. And so trying to avoid that would be good. But that's fortunately not super common, but that scenario is a particular problem that we run into. The highest risk person, no immunity basically by the measures we have, but maybe some reason we were really hesitant to reduce their immune suppression, like they had a high PRA, and that's partially how you got here in the first place. Those are challenging questions, and I think that tools like this are going to be helpful. We're just learning how to swim here with what to do.
Great, thank you. Then the next, what was the viral load cutoff you used to diagnose CMV disease aside from that clinical picture?
Yeah, so I think I mumbled it quickly. We don't have a specific cutoff. You know, we have had a few people come in who were, I would say, sick from CMV with viral loads of maybe only a few hundred international units per ml. Those are really rare. Most people have viral load in the thousands and climbing. And the people who come to, let's say they come to clinic and they're like, oh man, I've had these night sweats and I feel terrible and I've started to have some loose stools, and we look in their lab and their white count went from 4 to 2. Those people generally have a CMV of like 300,000 or something. It's not subtle. So we don't have a specific viral load, but the inflection point is somewhere between 1 and 5,000 IUs per ml, I think, as we sort of walk through this clinic.
Great. This next question, I think we answered it, but let me know if you feel like you have anything to add with one of the previous ones. But you stated that you remove patients from prophylaxis at 6 months, even if they don't have a sufficient TCIP response. What are your thoughts, or have you considered extending prophylaxis past 6 months for those patients with a low response? I know, I guess we applied it specifically to the D plus R minus situation, but broad level.
Yeah, so I will disclose that I'm kind of opposed to prolonging prophylaxis. It may be the right answer. I'm gonna have someone convince me of that. I think that if we're going to prolong their prophylaxis, we need to do something else. So it's cut their mycophenolate in half, or run their tacrolimus troughs lower. Something. I think to just blindly say, well, in 6 months they haven't achieved immunity, let's give them 3 more months. I think that's silly. So I think if we're going to entertain prolonged prophylaxis, we have to do something else that's going to give us confidence that now they're going to mount some immunity. So right now we still stop it. Yeah, this is another area of interest, we'll call it, that I think I'd like to study more and have some more objective data to drive decision making.
Absolutely. All right, and I know we're getting close to time, so this will be our last question for today. But did you notice any difference between the T-cell immunity response with immunity detected versus not detected for the high-risk donor-positive recipient-negative patients versus high-risk lytic induction patients?
We haven't analyzed that completely specifically, but in general, like broad terms, looking at the data set, I think that we're seeing more people who received lytic induction who are mounting immunity versus people who were recipient negative who are mounting immunity. Kind of like part of our previous discussion of, if they don't have any virus around, it's difficult to have their T cells learn how to go after it. In whether they have transient DNA or not while they're in prophylaxis is unknown. But so far, it seems like we have people who, like I said, like the lytic induction group has a pretty decent chance of getting immunity. The recipient negative don't seem to get immunity very often.
Okay. Great. Oh, okay. Do you have time for one more? I know we're pushing that 45-minute mark. Have you used the tests to extend antivirals in patients with recurrence after negative viral loads?
So we haven't used it in that setting yet. I think that you're seeing kind of, this is arguably still preliminary data as it is, and we're just learning like where else to look. And I think that's another area where it could be of use is sort of post-treatment. So when I trained, we were still doing post-treatment prophylaxis, which has kind of gone away, I think. But post-treatment risk stratification of like, so now you've had CMV and for whatever reason we decided to treat you. Now do you have immunity, or do you need to worry that you'll get, because refractory and or recurrent CMV is a real issue. In people, we've had people we've treated several times, and those are people who usually end up getting resistant strains, and it's a mess. And so I think that hopefully the T cell panel, applying that intelligently, I think will help us navigate that, but we have a lot to learn about it.
Yeah, absolutely. All right. Let's see here. I think I'm sharing my screen. If not, I wanted to say thank you to Dr. Miles for this fantastic presentation, this great Q&A to share your experience with the assay. I'd like to thank Dr. Kleibacher for coming on for the in-depth Q&A today as well. And to our viewers, thank you for joining us this afternoon. If you have any questions that we were not able to answer, I feel like this was a great Q&A, but if there are any others that you have and you didn't get them addressed during today's session, please go ahead and email events@eurofins-virocorps.com. I hope everyone has a great day and a fantastic holiday season. Have a great afternoon, guys.
Thank you very much.
Bye.
Bye-bye.